Thank you, Chair, and thank you, presenters. I have a question that goes to Madam Judith. Thank you for the presentation. According to the results that you are giving us, you indicated that the health workers were getting information. And my assumption is the information that you gave them through the training they already had. So the question is, did you do a baseline? What was it? What was the situation like when you started? Thank you. Thank you.
Is that 2 months behind?
Thank you. Question to Ms. Fatima Khan. So I'm quite interested in, healthcare equity through taxation. Taxation is a very, sensitive topic, especially in Kenya. So I think we have the same sort of setup where those who are employed are the ones who are taxed the most. So they are the ones who bear the burden in terms of now providing equity in the healthcare system. And if I can give you just more context, about 20% of our population in Kenya are the ones who are taxed. So the rest is probably through VAT and all that, but it's only about 20%. So I'd like to understand, is that the same case in Pakistan? What is the population, what percentage of the population pay tax? And do you believe that taxation is the best way to achieve healthcare equity? And if so, what is Pakistan doing to target the informal sector? Because like in Kenya, you find that the informal sector are earning some even more than those that are salaried, but they are not paying tax. So I'd like a general overview of Pakistan, if there's anything that's being done to target the informal sector, and what percentage of the population are being taxed. Thank you.
Okay, thank you. There was another hand in the middle there.
Thank you. So the first comment and question goes to Fatima. You mentioned that the right to live should be everyone's right, which I appreciate. Very student, but at whose cost? At whose cost? Because we do believe that healthcare comes at a cost. I'm wondering if you have considered health insurance as it's done in Kenya, though we have also just confessed that it's only 20% that are paying the taxes. So I'm wondering who is insured and who's not. So that is one. That then Harrison, I was wondering, I think your friend is from Kenya. If only 20% are insured, who is being covered by your national health insurance? Of course, you want to eliminate scarcity. How? Scarcity is here with us. You mentioned that you want to eliminate scarcity, that it should be the way, because that's why you went for, that's why you insisted on ration. But scarcity is here with us. We don't have enough resources. We just have to figure out a way to live. Our countries are interesting. Uganda, I think we visit 4.4% as per last financial year. Yet the Maputo declaration has it's I think it's 10%. So I'm one of those who are being taxed, but I would believe if we were to look at how ethical and how feasibly we can address this fact, this is my personal opinion, that insurance is key. And this business of universal access for everyone, that's a fallacy. I don't believe that one can be attained. Thank you.
So let's keep our questions brief and straight to the point.
Thank you. I have a question for someone. He looks at the ethical implications and looking at gender. In ethics, we are also looking at community engagement. So I'm interested in understanding the community engagement models that are looking at men to seek the healthy services. And if they could also like adopt or learn from how like the youth settings are doing, like ensuring that the services are youth friendly, which is why youth like now are opening up. That's why we see like peer educators. So, is it also like applying in this? Thank you.
Thank you very much. I think all our presenters have a question each. So we'll give you a chance to answer that, and then we'll have another round of questions. Please be brief as you answer.
Okay, thank you very much. Someone asked what was the situation like when we started the training. The Community and Place Station workers per se, they are still trainees. They had abstract knowledge, just like someone, you go and ask someone, how can you prevent malaria in the community? Of course, they've heard about the use of mosquito nets, but what is their attitude like? So they had that abstract knowledge. It wasn't entirely new to them, but they wouldn't use the knowledge to make informed choices or to transition behaviors of the communities. Yeah, so the study was carried out around 1.5 months and 2 months into the training. They told us their misconceptions they had and how these misconceptions have changed into the right information and a community engagement. Thank you.
So someone asked me about the healthcare equity through taxation and the tax system in Pakistan. So in Pakistan, what we have is like most of the taxes are being paid by the salaried class, and it is being deducted at source. Between 2018 and 2015, the taxes have been increased from around 19% to 29% on the salaried class, while most of the informal tax sectors are not being taxed. Pakistan being an agricultural country, we don't have taxes on agriculture. So this is a big problem. This is also something that is creating a lot of disparity and reluctance in taxpayers in achieving the equity. Also, there are certain reforms that are being done in provincial, like in Punjab, Pakistan, there are certain tax slabs are being introduced in agriculture to tax large landowners and not to burden the smaller farmers. Something is being done, but a lot is still left to be done here. And there's someone else who asked something that unfortunately I couldn't hear.
Thank you so much, my brother. By this student, I asked about how can we, if possible, convert the Russian completely. Remember, in my conclusion, I threw it back to the stakeholders in the audience by requesting if possible. However, I would answer on my personal perspective. The continent of Africa had a declaration which we call Abuja Declaration, where most of the nations ratified this declaration, demanding that every nation should at least allocate 15% of their total budget to health. As a country, the highest budget from what I've been reading so far it has gone to 7.1. Most of them have reached between 4, 5, 6. That is including even the global supports. It means if we could try to adapt Abuja Declaration as we have ratified it, then possibly we would completely reduce these rationing issues, which at one point the community is blaming the frontline health workers, but also our normative rules tell us that you go to the hospital, you will access the healthcare services, but it's not there. I would also concur and agree with you on the issue of this national insurance policy. It's still available if we could adapt. But the question which I think recently the president also talked about it, is how will that common person down there in the village will benefit. If you agree that me, if I'm working, I pay that insurance policy and equal access to care to everyone, irrespective of how much you pay based on your income, then I think it would work and try to address this. Thank you.
Okay, thank you. Thank you for the question. Regarding the community engagement models, I equally believe it's one of the ideal approaches that can be used to address this existing disparity. However, it has to be implemented with the aspect of inclusivity, because at the end of it all, when you realize the men are not there simply because they tend to be too busy. But now, how are you going to engage them if they tend to be too busy within the workplaces and so on? So you have to design a way how to engage these men and make sure that they are part of the approach or the model you are intending to implement to address this problem. And also still on the issue of community engagement is that this disparity is partly shaped by social norms that are based on stereotypical perceptions, where somebody thinks this is how man is. So the only way we can demystify such perceptions is to go into communities to create awareness. So that would be a good approach to address this disparity. Thank you.
Thank you so much. Maybe there was a question about how we can achieve equity when only 20% are the ones who are contributing. Maybe just to say that in Kenya we are now transitioning from NHIF to SHA. And SHA as an insurance has 3 packages. It has what we call the PHC fund, it has the SHIELD fund, and it has also the emergency and the chronic fund. Now for any citizen who is registered under SHA, when you visit level 2 facilities, you are able to get services free, and even if you are not paid. And that you get those services under what we call the primary healthcare fund. And the facilities are now able to claim the cost to SHA. So that's what we are doing to just at least increase the scope of universal healthcare coverage for the citizens. Then another thing that that I also wanted to also maybe discuss is the FIF Act of 2023 that has also been done. Now this now gives these facilities, after they have claimed this money from SHA, it gives them powers to retake the money and budget it as a facility. So that makes the facility to be in a position now to provide all the essential services. But that's what is happening within Kenya. Thank you.
Thank you very much. Can we take, do you still want more questions?
Yeah.
Mixed answers here. I think we have one question. Anyone else?
For taxation, and that is from Pakistan. I was wondering what are some of the issues, but you mentioned one, and my question is, what are your proposals?
Okay, so again, the Commonwealth recommendation is to first of all, we need reforms in taxation. So first of all, we need to introduce transparency. So to improve people's trust in tax system and redistribution. Secondly, reforms should be made to include informal sector, which which is a big part of GDP, but they're not accepted here. They're not inclusive in tax. Being an agricultural country again, a larger portion of agriculture is not being taxed. So all these, we need to increase tax net. This is the solution, first and foremost. Until unless we increase the tax net, include the informal sector and the agriculture, we cannot achieve the kind of equity, because that will be another form of inequity. and the burden would only be on the salaried class.
You mean increasing or expanding?
Sorry?
Expanding or increasing?
Expanding the tax net. Yes.
Then the other question was on another person. Right? Sure. The first presenter was Eve Namita. I was wondering why you focused on that. Why you focused on that location? When we talk about ethics, we want to know whether you are also marginalizing them or.
Okay, in the first place, I'm a national trainer and I'm attached to Namaingo district for the community health extension workers. Secondly, Namaingo is highly burdened with teenage pregnancy. It is actually the leading district in teenage pregnancy, but it also has disparities in maternal and child health, so it makes our assessment much more contextualized and specific to the district.
And the last question was on, my own. The last question was on, I think that was Solomon. Yes, how can men get full access to health care? Because that was not very well, because you talked about TB only, right? But how can men get full access? You are not going to stop them from work, but what are your proposals?
Okay, thank you very much for that question. One of the suggestions would be integrating care, one stops like where men can go, and then oftentimes when they go to facilities, they have this time to be as patient as expected. So it's better. One of the things is integrating the care within a certain stop point where they can get the care, but also the other option would be male-friendly services. By male-friendly services, what do I mean? Extend on working hours, considering that men come in a bit late, but also make sure that you can present to them like a male champion, somebody who can talk to them and they feel more fluid. Those could be some of the options to try and adjust on their access to care. Why do men want to work when they are sick? Why can't they just go to hospital? It will solve the whole problem.
My questions are to Fatima and Okot. And this question probably can be answered by both. In all of this taxation business and rationing and resources, how to get them provided equitably. You talk about the gap increasing taxation, but I'm interested in what the role of corruption has in all of this, because we have a challenge whereby, and that generally affects even the little tax base we have, where people feel that they provide taxes and then the money is taken. So that ends up leading to problems of rationing that Dr. Okot is talking about. I just want to comment about that. And then also finally for Okot, I was interested in what did you find as the effect of that rationing? What did the patients think? How did it affect them?
So let's take the last question.
Yeah, I have two questions. One to Judith and then another to Okot. Judith, you showed us very interesting results that there was improvement in knowledge. How are we sure that knowledge can translate into tangible community benefits though? And then maybe the other one is about the issue of rationing. How did it impact on those workers themselves?
Okay. Who wants to start? Keep along. Please be brief.
Thank you. Let me start here. The impact of this corruption to health workers to help them provide them. One of the things I found out was having the capacity or the intent to give the standard care to the patient, but you don't have the required material supplies to deal with this issue. A term which I tried to explain called moral injury, where I said there's a psychological distress where a frontliner feels that he or she would have given a better care to the patient, but could not do because the patient doesn't have capacity, if at all, sent to go and do a test, certain tests, or buy certain drugs for intervention. Two, the facility itself doesn't have those resources, so it brings that distress. Not burned out, but distress. For doctor, I think the effect on the patient came from, because my study participants excluded the patient, but I got that feedback from the participants also, that there will be substandard care to the patient. Because, for example, you don't have enough beds, then you find that this patient A is slightly improving, but another critical ill patient comes in, you need to discharge this one earlier on, and you admit this one. So in the event, but you don't even have the capacity to follow this one going out. So that's what I found. Thank you.
Okay, and you give it to.
So there was one question about taxation and corruption. So this is a huge problem back in Pakistan also. And yes, this also leads to the fact that it creates a lot of distress in public and taxpayers, and then they try ways to, evade tax paying, and then in return, the disparities and inequities increases further. So yes, this is a problem. I think the only thing we can do, or the state can do, is to be transparent about collection of taxes and their redistribution. Where are they being used, so that people should know that they're paying for this. This is their taxes are being used for. So transparency and expanding the tax net, and this is the only way to go. I think yes, corruption is an issue, but transparency could only be our way forward.
Okay, thank you. The question of how sure are we that knowledge can translate into tangible practices in health? So the kind of training for community health extension worker cadre is a 3-to-2-to-1 approach, where we have 3 months of lectures, role plays, demonstrations, field visits, and so on. But they also have 2 months in the field to practice what they have learned. And during these 2 months of field practicum, we, the trainers, have to go and assess what they are doing, what change are they creating in the community, what practices are being done in the community as a result of the training for the community health extension workers. So we have observed some of these things that are being done. We go to homes, we assess the hygienic levels of the home, because we know we sent our community health extension workers to do a change in the community. We look at the behavior in the communities that are happening. We check also in the health facilities, because they go to health facilities, but they also go to communities. We ask how many people are coming from this parish and they are requesting for family planning services. Is there a change in home deliveries and delivery from health facilities? Are the people coming to utilize? So we continue monitoring them, they provide us with feedback, and at least we see that there is change. And therefore we believe that the knowledge we are imparting in them is translating into action. Thank you.
Thank you very much, everyone. I think I'm going to go to the last one now. I want to give each of the presenters just 30 seconds or so to tell the audience what you want them to remember about your work. Just a brief summary so that they can be able to be interested to have lunch with you and discuss more.
Okay, thank you very much. I strongly believe that empowering community health extension workers is key to addressing equity gaps, because health starts in the communities. If a community doesn't really know about what they are supposed to do or how they are supposed to conduct themselves, then there is no way they will do the required action. So health begins in communities, health begins in homes. So the community health workers interacting with these people, at least we shall know that the equity gaps are also solved.
So empower communities.
So, healthcare, as I said before, is health is human right and should be provided to everyone, and it is important to achieve healthcare equity. Tax on a community level or on a state level, taxes are the only way we can achieve the kind of healthcare equity that we need. Also, we need to understand that taxes are not fees for private services. Taxes are constitutional obligation, and we can only move forward by realizing that this is our constitutional and ethical duty, and it is the most just thing that we can do.
Thank you.
Thank you. Improving preventive measures and therapeutic measures with respect to disease would reduce the number of patients or number of people visiting the hospital, and possibly would help us to address the issue of rationing. Thank you. Because it will be cheaper to do a preventive measures than treatment.
Thank you. Reducing the demand. Thank you. TB knows no masculinity. Those all seek care where necessary and encourage colleagues, whether you're a man, a woman, encourage the other to access the care, because at the end of it, it affects us all, the fact that we interact with each other. Okay, thank you.
Thank you. For us to do it, we have to invest heavily in primary healthcare. And for us to be able to understand how best we are investing, then you have to put in the aspect of performance management in private healthcare, where we can now be able to look at the data we have and turn it into implementable actions, and that will change the health space. Thank you.
Thank you so much, and I believe you agree with me that these guys have done some justice to a very difficult topic. Let's clap for them. Thank you so much for coming to present your work here. And please, if you have any further discussions that you want to hold with them, they're still available. I would like to give you 3 minutes back of your time. And thanks for giving time.